Welcome to the deep dive. Today, we're tackling a topic that's really foundational for nursing, blood pressure.
It really is. It's so much more than just numbers on a monitor.
Exactly. It tells us how well the body's delivering oxygen, nutrients, getting rid of waste. And for nursing students understanding this, well, it's absolutely critical for safe practice.
Couldn't agree more. Especially when you think about giving meds, spotting changes in a patient's condition, you need to know the why behind the pressure.
Right. So our goal today, our deep dive mission, is to equip you with that core knowledge. We'll look at normal BP control, how drugs affect it.
And we'll touch on using these drugs across the lifespan, how they work the pharmacology bit.
Yeah, pharmacokinetics, side effects, interactions, all that. Plus, comparing different drug classes, and importantly, the nursing side assessments, patient teaching.
So basically distilling the must-know info for foundational nursing practice.
Exactly. Let's jump in, starting with the basics. How does the body normally control blood pressure? Our sources talk a lot about mean arterial pressure, MAP.
Right, MAP. Think of it as the average pressure pushing blood into your tissues over a full heartbeat cycle. It's a really good indicator of how well organs are being perfused.
Better than just systolic or diastolic alone.
Generally, yes. It gives a more constant picture.
Okay, and what determines MAP? I remember heart rate and stroke volume.
Yep, heart rate times stroke volume gives you cardiac output, how much blood the heart pumps per minute.
Got it,
Yep.
cardiac output. And the other factor was resistance.
Peripheral vascular resistance, PVR. So MAP is basically your cardiac output times that resistance the blood faces in the vessels.
And when we talk about that resistance, PVR, it's mostly the little arteries, the arterioles doing the work.
Exactly. They have smooth muscle that can tighten up vasoconstrict or relax vasodilate, like adjusting a hose nozzle. Tighten it, resistance goes up, pressure goes up.
Makes sense. And controlling that tightening and relaxing, that's the autonomic nervous system.
Spot on. The automatic part of our nervous system. You've got the parasympathetic and the sympathetic branches.
Parasympathetic is the rest and digest, right? Lowers BP.
Generally, yes. It slows the heart rate, maybe decreases how hard it contracts a bit, brings things down.
And sympathetic is the fight or flight.
Right. That ramps things up, increases heart rate, makes the heart beat stronger, and causes vasoconstriction in most arterioles.
So that increases the PVR we talked about.
Exactly. Increases PVR, increases MAP. It also constricts veins, squeezing blood back towards the heart.
Wow. Okay, so these two systems are constantly balancing things. Where's the control center for all this?
It's mainly in the brainstem, in the medulla and pons. There's an area called the vasomotor center.
And it gets signals from all over, even higher brain areas.
Yeah, stress, emotions. They can influence it via pathways from the cortex and hypothalamus down to the vasomotor center.
Okay, this is where it gets cool. The body's own feedback systems, like the baroreceptor reflex. What are baroreceptors?
Think of them as pressure sensors, like little stretch detectors. They're located in key spots, the arch of the aorta and the carotid arteries in the neck.
Monitoring the pressure going to the body and the brain. Smart.
Very. They constantly sense how much the artery wall is stretching.
And if pressure goes up, what do they tell the brain?
If they detect too much stretch, meaning high BP, they fire off signals to the medulla. The medulla then says, okay, let's bring this down.
How?
It ramps up the parasympathetic signals, slowing the heart, reducing output, and inhibits the sympathetic signals, causing vasodilation. Lowers the pressure.
And if pressure drops too low, like when you stand up quickly?
The classic example. Gravity pulls blood down, pressure in the carotids drops, less stretch. Baroreceptors sense that.
And they tell the medulla.
Pressure is falling. So the medulla quickly dials back parasympathetic activity and boosts the sympathetic system.
So faster heart rate, stronger beat, vasoconstriction.
Precisely. Brings the pressure right back up to keep blood flowing to your brain so you don't get dizzy or faint. It's usually super fast.
Amazing. Our sources also mention chemoreceptors briefly. They sense blood chemistry.
Yeah, mainly low oxygen, high CO2, or high acid levels. They can trigger the vasomotor center to increase BP, but it's usually more significant if the BP is already quite low, like below 80 systolic.
Okay, so baroreceptors are the main moment-to-moment regulators. What about longer-term control? That brings us to the RAAS, right?
The renin-angiotensin-aldosterone system. Absolutely key, especially when we talk about meds later. This is a major hormonal player.
How does it get started? Low BP again.
Low BP sensed by the kidneys, or maybe just poor oxygenation to the kidneys. That triggers specialized cells there, the juxtaglomerular cells, to release an enzyme called renin.
Renin, okay. What does renin do out in the bloodstream?
It finds a protein made by the liver called angiotensinogen.
Angiotensin is quite a mouthful.
Isn't it? Renin chops a piece off angiotensinogen, turning it into angiotensin I.
Angiotensin I, is that the active one?
Not really. Angiotensin I is more like a precursor. It needs another conversion, travels through the blood, and when it gets to the lungs, mostly.
And MESAC.
Exactly. Angiotensin-converting enzyme, ACE.
The target for ACE inhibitors. Got it.
So ACE converts angiotensin I into angiotensin II, and angiotensin II is the really potent one.
Potent how? What does it do?
Two main things, really powerfully. First, it's a massive vasoconstrictor. Clamps down on blood vessels all over the body.
Increases PVR and BP immediately.
Right. Second, it goes to the adrenal glands on top of the kidneys and tells them to release aldosterone.
Aldosterone. That affects sodium in water, doesn't it?
It does. Aldosterone tells the kidneys to hold on to more sodium, and where sodium goes, water follows.
So you retain fluid, blood volume increases.
And increased volume also means increased pressure.
Wow. Vasoconstriction and volume expansion. And isn't there ADH involved too? Antidiuretic hormone?
Yep. That increased sodium concentration in the blood signals the hypothalamus in the brain.
Which tells the pituitary to release ADH.
Exactly. ADH goes to the kidneys and tells them to reabsorb even more water directly. More volume, more pressure still.
It's like a cascade effect.
Yeah.
How does it stop? Is there a negative feedback?
There is. Once blood pressure rises and blood flow to the kidneys improves, those juxtaglomerular cells sense it and release less renin. Less renin means less angiotensin II, less aldosterone, and the system quiets down. It's a self-regulating loop.
Our sources have some diagrams, figures 43.1 and 43.2, that apparently lay this all out visually. Helpful to picture it.
Definitely helps to see the flow.
Okay, so that's normal regulation. Now the flip side, hypertension. Sustained high BP. It's super common, isn't it?
Incredibly common. A huge public health issue in the U.S. And worryingly, lots of people have it and don't even know.
The silent killer idea.
Exactly. No obvious symptoms early on. And even for those diagnosed, getting it under control, well, it's often a challenge. Only about half achieve good control.
And there's different types, essential versus secondary.
Right. In most cases, maybe 90% are essential or primary hypertension, meaning we can't point to one single underlying cause. It seems to be a mix of genetics, lifestyle, leading to increased PVR.
And it's often asymptomatic for a long time.
Very often. The other 10% is secondary hypertension. That's high BP caused by another condition.
Like the example in the source of pheochromocytoma, that adrenal tumor.
Yeah, that's a classic, though rare example. The tumor pumps out adrenaline-like hormones, driving BP way up. Treat the tumor, and the BP often normalizes.
But whether it's primary or secondary, chronic high BP is bad news for the body.
Very bad news. It damages organs over time, the heart, kidneys, brain, eyes, the blood vessels themselves.
How does it damage vessels?
The constant high pressure injures the delicate inner lining, the endothelium. That injury promotes atherosclerosis plaque buildup.
Which leads to heart attacks, strokes?
Exactly. Plus, the heart has to work harder against that high pressure. The left ventricle can thicken hypertrophy, which isn't good, increases heart failure risk.
And damage to small vessels affects kidneys, eyes, brain.
Yes. Tiny vessels in the retina get damaged, impacting vision. Kidney filtering units get scarred, leading to renal dysfunction or failure. And brain changes can occur too. It really increases the risk for coronary artery disease, stroke, kidney failure, vision loss.
Hence, the urgency to detect and manage it, even without symptoms.
Absolutely. Which can be tough, convincing someone who feels fine to take medication, possibly with side effects. Patient education is key.
What puts people at higher risk, besides family history?
Lots of things. Getting older, smoking, high salt intake, too much alcohol, not enough exercise, obesity, insulin resistance, chronic stress, sleep apnea.
Diabetes, chronic kidney disease too, right?
Definitely. All major risk factors.
Our sources mention the AACC categories for BP, normal, elevated, stage 1, stage 2.
Right, based on systolic and diastolic numbers. Those categories help guide treatment. Generally, meds are recommended for stage 1 if the person also has high cardiovascular risk, and for everyone with stage 2.
And the first choice of medication, it can differ based on ethnicity.
The guidelines suggest that, yes, for non-African Americans, options often include a thiazide diuretic, a calcium channel blocker, an ACE inhibitor, or an ARB.
But for African American adults?
Thiazides or calcium channel blockers are often preferred initially, as studies suggest they tend to work better in that population, though individual responses always vary, of course.
The main goal is always to get the BP to the target range and keep it there.
Right. That might mean starting one drug and increasing the dose, or maybe adding a second drug from a different class if needed. Sometimes combination therapy right from the start.
And ACE inhibitors and ARBs, don't use them together.
Generally, no. Avoid that combination. And if things are complex, a specialist might get involved.
What about white coat hypertension? BP high in the clinic but normal at home.
Yeah, it's a real thing. Probably anxiety related. It just highlights how we measure BP is so important.
Definitely. Using the right cuff size, patient relaxed, arm supported, cuff on skin, listening carefully for those Korotkov sounds.
All crucial. And home BP monitoring, having the patient keep a log, that can be really valuable too. Gives a much better sense of their usual pressures.
So the medications basically work by tweaking those regulatory systems we talked about earlier.
Exactly. Targeting the nervous system signals, the RAAS, vessel dilation. It's usually about managing essential hypertension, not curing it. Treatment has to be individualized.
There are even fixed-dose combination pills available, right, to simplify things.
Yes, combining 2 different drug types in one pill can help with adherence sometimes. And just a note, pulmonary arterial hypertension is a separate beast, needs very specific treatments.
The stepped care approach is also mentioned. Lifestyle first.
Yep, step 1 is always lifestyle. Diet, exercise, weight loss, salt reduction. If that's not enough, step 2 is usually starting a drug diuretic, ACE, ARB, calcium channel blocker.
And then adjust dose, switch, or add drugs as needed.
That's the general idea. Step up the therapy until the goal BP is reached.
Any special considerations for patients with chronic kidney disease?
Yes. ACE inhibitors, or ARBs, are often the first choice, especially if there's protein in the urine albuminuria. They seem to offer some kidney protection beyond just lowering BP.
And finally, the cultural point, again, African Americans having higher risk and different responses.
Right. Higher risk, maybe less response to ACE-ARBs, often better response to diuretics and calcium channel blockers. So early screening is vital, and initial therapy often starts with those latter 2 classes, plus lifestyle changes.
Okay, let's dive deeper into some specific drug classes, starting with those affecting the RAAS system, ACE inhibitors, ARBs, renin inhibitors.
Right, all targeting that renin-angiotensin-aldosterone cascade we mapped out. Very effective drugs. Let's start with ACE inhibitors.
Angiotensin-converting enzyme inhibitors, they block that ACE enzyme mainly in the lungs.
Exactly. They stop angiotensin tests from becoming the potent angiotensin II.
So less vasoconstriction?
Less vasoconstriction, yes. Also less aldosterone release. That means the kidneys let go of more sodium and water, and they tend to hold on to a bit more potassium.
Whoa.
So serum potassium can rise slightly.
And besides hypertension, what else are they used for? Heart failure.
Yes. Key drugs for heart failure. Also used after heart attacks to protect the left ventricle, and importantly, in diabetic nephropathy, to slow kidney damage progression.
How are they usually given? Mostly pills.
Almost all are oral. Enalaprilat is an IV form, but mostly pills. They're generally absorbed well, get metabolized by the liver, excreted by the kidneys.
Big point, though, they cross the placenta.
They do, and they get into breast milk. So big contraindication, pregnancy. They can cause serious harm to the fetus. Avoid in breastfeeding too.
Who else shouldn't take them? Allergy, obviously.
Yes.
Angioedema.
Yes. Anyone with a history of angioedema, that serious swelling, especially if it was linked to an ACE inhibitor before. Use cautiously in kidney impairment, severe heart failure, or someone's dehydrated.
What about side effects? What should patients know?
Well, hypotension, especially at first. Maybe some dizziness. GI upset can happen. Rash. And then there's the classic ACE inhibitor cough.
The dry, annoying cough.
That's the one. Thought to be related to bradykinin buildup. Also, angioedema is a risk. The low less common, but serious. And hyperkalemia, that high potassium level, needs monitoring.
Are there interactions to watch for? NSAIs.
Yeah, NSAIDs can sometimes blunt the effect of ACE inhibitors. Taking them with other BP meds or diuretics can cause too much of a drop, so monitor closely. And combining with potassium supplements or potassium-sparing diuretics. Big risk of hyperkalemia.
Anything with food.
Most can be taken whenever. But captopril and moxapril work best on an empty stomach, like an hour before eating.
Captopril is the prototype mentioned. Anything specific to highlight?
Just reinforces the main points. Blocks ACE, used for HTN, heart failure, diabetic kidney disease. Watch for cough, angioedema, hyperkalemia, kidney function. Take on empty stomach.
So nursing care for ACE inhibitors. Check allergies, kidney function, pregnancy status, baseline BP, potassium levels.
Absolutely. Assess for dehydration. Plan for effective BP control with minimal side effects. Patient education is huge.
like teaching about the cough, reporting swelling, importance of follow-up labs, dietary sodium, potassium awareness.
And alerting surgeons if the patient is on one before surgery because of potential low BP during anesthesia, and emphasizing adherence even if they feel fine.
Okay, moving along the RAAS pathway. Angiotensin II, receptor blockers, ARBs. How are they different from ACEs?
They work one step later. Instead of blocking the production of angiotensin II, they block the receptors that angiotensin II binds to.
So angiotensin II gets made, but it can't do its job, like vasoconstriction or telling the adrenals to make aldosterone.
Exactly. It blocks the message from getting through. The end result is similar. Lower BP, less aldosterone effect. Examples are drugs like losartan, valsartan.
And used for similar things, hypertension, heart failure, diabetic nephropathy.
Generally, yes. Similar indications to ACE inhibitors. Some are approved for kids with hypertension, too.
Administration, also oral.
All oral. Absorbed, metabolized by the liver, often the P450 system excreted in feces and urine.
And pregnancy, same issue.
Same major issue. Contraindicated in pregnancy due to fetal harm risk. Avoid in lactation, too. Need contraception advice for women of childbearing potential.
Contraindications similar too. Allergy, angioedema history, caution with liver-kidney issues.
Pretty much, yes, and caution if hypovolemic.
Side effects. Is the cough less common with ARBs?
Generally thought to be less common than with ACE inhibitors, though can still occur. Other common things are dizziness, headache, weakness from the lower BP, maybe some GI upset, fatigue. Still need to monitor kidney function.
Drug interactions, similar warnings about potassium, other BP meds, NSAIDs.
Yes, very similar interaction profile to ACE inhibitors regarding those points. Monitor BP, potassium, kidney function, lithium levels, if applicable.
Losartan is the prototype ARB mentioned. Key takeaways.
Blocks angiotensin II receptors. Used for hypertension, diabetic nephropathy. Oral use. Watch for dizziness, hypotension, kidney function. Monitor for angioedema.
Nursing care for ARBs sounds very parallel to ACE inhibitors then. Assessment, checking labs, pregnancy status, education about side effects, adherence.
Very parallel. Assess for allergies, liver kidney function, volume status. Ensure patient understands contraception needs if relevant. Monitor BP, electrolytes, alert surgeons, provide thorough teaching.
And the third RAAS drug class mentioned is the direct renin inhibitor, aliskiren. How does that work?
It goes right to the beginning of the cascade. It directly blocks the enzyme renin itself.
So it stops renin from converting angiotensinogen to angiotensin I.
Exactly. Less angiotensin II down the line. Lowers BP.
Is it used a lot?
Maybe less commonly than ACEs or ARBs. Absorption can be tricky, affected by fatty foods. It have a long half-life.
Same pregnancy warnings?
Yes. Crosses placenta, avoid in pregnancy and breastfeeding. Same risks of hyperkalemia, angioedema, kidney issues. Diarrhea is a noted common side effect, and definitely avoid combining with ACEs or ARBs usually.
Okay, let's switch gears entirely. Calcium channel blockers, or CCBs. How do they lower blood pressure?
They block calcium from entering muscle cells, specifically in the heart muscle and the smooth muscle of artery walls.
And calcium is needed for contraction.
Right. So less calcium entry means less forceful contraction of the heart, potentially a slower heart rate, and importantly, relaxation or dilation of the arteries.
Wider arteries mean lower resistance, lower PVR.
Lower BP. Exactly.
Yeah.
They also reduce the heart's workload and oxygen demand, which is why they're also used for angina. Lots of oral options like amlodipine, diltiazem, nifedipine. Clofidipine is only for hypertensive emergencies.
Are there different kinds of CCBs?
Broadly, yes. The dihydropyridines, like amlodipine and nifedipine, mostly work on the blood vessels causing vasodilation. They have less effect on the heart rate itself.
Okay. Mostly vessel dilators. And the other kind.
The non-dihydropyridines, like diltiazem and verapamil, they work on both blood vessels and the heart. They slow the heart rate and reduce contractility more significantly.
Which makes them useful for some arrhythmias, but maybe risky in heart failure?
Exactly. They can worsen heart failure sometimes because they reduce the heart's pumping strength. So you choose based on the patient's overall picture.
How are they handled by the body? Oral absorption, liver metabolism?
Generally, yes. Most are oral, well-absorbed, metabolized by the liver, excreted by the kidneys. They do cross the placenta and get into breast milk, so caution needed in pregnancy lactation.
Contraindications. Besides allergy, heart block for the non-dihydropyridines.
Yes, heart block, sick sinus syndrome, sometimes severe heart failure, contraindications for diltiazem and verapamil. Caution with liver-kidney dysfunction for all of them. Pregnancy is often a relative contraindication unless benefits outweigh risks.
And those extended release ones, don't crush them.
Absolutely not. Swallow them whole. Crushing an extended release pill delivers the whole dose at once, dangerous.
Common side effects. Dizziness again.
Dizziness, lightheadedness, headache, fatigue, common with BP lowering. Also, constipation can be an issue, nausea sometimes, cardiovascular effects like hypotension, bradycardia, especially non-dihydropyridines, and peripheral edema, that ankle swelling, are quite common. Flushing, rash too.
Any big drug interactions?
They can interact with various drugs. A specific one mentioned is diltiazem increasing cyclosporine levels.
And the grapefruit juice interaction. That's a big one for CCBs, right?
UGE1. Grapefruit juice inhibits the enzyme that breaks down many CCBs in the gut wall and liver.
So you end up with much higher drug levels, more side effects, toxicity.
Exactly. Patients absolutely need to be told to avoid grapefruit and grapefruit juice while taking these medications. Always ask about it if toxicity is suspected.
Diltiazem is the prototype CCB mentioned. What's key about it?
It's a non-dihydropyridine used for hypertension, usually extended release, angina, some arrhythmias, slows heart conduction, decreases contractility, dilates vessels. Oral or IV. Watch for dizziness, headache, edema, bradycardia, hypotension.
Nursing care for CCBs and hypertension, besides the angina stuff. Assessment for heart issues, liver kidney function, checking for edema.
Right. Assessing for interactions, especially grapefruit. Baseline vitals.
Yeah.
Planning for BP control. Minimizing side effects.
Interventions like teaching not to crush extended release, maybe take with food for GI upset, safety for dizziness, monitoring DP and heart rate closely.
And that crucial grapefruit juice education. Also teaching about reporting side effects like swelling, shortness of breath, persistent dizziness, importance of adherence, avoiding abrupt stopping.
Let's touch on that critical thinking scenario about BR. The African-American man with stage 2 hypertension, reluctant about the diuretic, prescribed a CCB, asking for more time for lifestyle changes. What are the nursing priorities there?
Well, first, you have to acknowledge his efforts and concerns. Validate his reluctance about the diuretic, maybe explore why, then provide really clear education.
About the risks of stage 2 hypertension, the realistic chances of lifestyle alone working at this point, the benefits and potential side effects of the CCB.
Exactly. A shared decision-making approach is ideal. Maybe agree to a short, closely monitored trial of intensified lifestyle changes, but stress the importance of starting meds if BP doesn't respond quickly.
Address his other concerns too, like insurance or job worries if you mention them.
Absolutely. And ensure he knows how to take the CCB when he starts it, what to watch for, and the importance of follow-up. Praise his successes with lifestyle changes so far.
The care guide for him would emphasize that assessment, planning for safe BP reduction, and interventions focused on education, monitoring, and support.
And the patient teaching specifically for him on the CCB would cover everything. Drug name, why he needs it, how to take it, side effects, common and serious, the grapefruit rule, not stopping suddenly, checking OTC meds, safety precautions.
Okay, let's quickly cover the other side of the coin. Hypotension, low blood pressure. Why is that dangerous?
Because if it's too low, organs don't get enough blood flow, enough oxygen. Severe prolonged hypotension can lead to shock, where cells start dying, organs fail, life-threatening.
What causes it, besides maybe too much BP medication?
Could be heart damage, like from a heart attack, severe blood or fluid loss hemorrhage, dehydration, problems with the autonomic nervous system.
And orthostatic hypertension, the dizziness on standing.
Yeah, that's specifically a drop in BP when changing position from lying, sitting to standing. Blood pools in the legs momentarily, less blood gets to the brain, common in older adults or with certain meds.
How do we treat low blood pressure? If it's severe, like shock.
That often requires vasopressors, drugs that raise BP, sympathetic agonists like dopamine, norepinephrine, epinephrine. They stimulate adrenergic receptors to constrict vessels, maybe make the heartbeat stronger. They're powerful drugs with potential side effects used carefully in critical care.
What about for less severe, chronic orthostatic hypotension?
If lifestyle things like fluid, salt, compression stockings don't work, a drug called midodrine might be used.
How does midodrine work?
It's an alpha agonist. It specifically activates alpha receptors on blood vessels, causing them to constrict, raising vascular tone and BP.
Any specific cautions with midodrine?
Yes, it can cause high blood pressure when the person is lying down, supine hypertension. So it should really only be taken when the patient is going to be upright and active. Contraindicated if they already have supine hypertension. Also, caution in heart disease, kidney disease. Side effects can include goosebumps, chills, dizziness, bradycardia.
Another drug mentioned is droxidopa.
Yes, for neurogenic orthostatic hypotension. It gets converted to norepinephrine in the body, helping constrict vessels. Also has risks, like supine hypertension. needs careful management.
So overall nursing considerations for any antihypertensive drug, whether raising or lowering BP, it always comes back to assessment.
Always. Allergies, other conditions, kidney liver function, pregnancy status, current meds, baseline vitals, including orthostatic readings.
And interventions focus on monitoring BP and heart rate closely, especially with dose changes.
Absolutely. Timing administration correctly, safety precautions for dizziness or falls, thorough patient education about the specific drug, its effects, side effects to report, adherence.
And for drugs like midodrine, specific teaching about only taking it when upright.
Crucial point for midodrine.
Okay, so wrapping up this deep dive, we've covered a lot of ground. Normal BP control via the nervous system and RAAS, the dangers of hypertension, the principles of antihypertensives like RAAS inhibitors and CCBs, and a quick look at hypotension and its treatment.
It's truly foundational knowledge for nursing. Understanding these mechanisms and medications is essential for safe medication administration, effective patient monitoring, and crucial patient education.
Which leads us perfectly into our final thought-provoking question for you listeners. Considering this intricate balance of blood pressure regulation and the diverse ways these drugs work, what would you say are the absolute most critical assessment skills a new nurse needs to hone to ensure patient safety when giving drugs that affect blood pressure? Something to really reflect on.
Great question to ponder. Thanks everyone for joining us on this deep dive. Keep studying, keep questioning, and keep learning.